We are finishing up chapter 45 for AD1, which focused on our renal. Sorry about that, our renal system. And we ended off with looking at our UA labs. And I wanted to just hit on that one more time. There's a couple of them I missed in there. So we're going to hit on some of our more invasive diagnostic studies, and specifically our radiology parts of it. The other thing we need to talk about is age-related changes. So let's just recap on this. Creatine clearance is 7 to 135. So I'm going to just abbreviate it. CC is 70 to 135. And remember that is the amount of creatine in your urine versus the amount that is in your blood. So blood versus urine. Blood, actually, just to be correct here, we'll write urine over blood. That's how the formula is. Alright, and again, creatine should be coming out. Your blood is your blood urea nitrate, and again, that should also be excreted. And it's that byproduct of protein. It's 6 to 20. Normally we hear 15 as being a normal amount. Creatine, when in the blood, and I'm specifying this to not cause confusion, but when you take a blood sample of creatine, it should be relatively low. And again, that's because it should be going out in the renal system. Your white blood cells, again, this is always going to vary, but at 10, 5. And again, we need to look at the nursing responsibilities as far as these diagnostic tests go. Let's recap on our electrolyte. Sodium is 135 to, and this is in your serum. This is serum sodium, so we're talking about it in the blood. So 135 to 145. Potassium is 3.5 to 5. Calcium is 8.6 to 10.2. Your phosphate is going to be 2.1 to 4.4. Sodium, calcium, phosphate, and I feel like I'm seeing, bicarb. Bicarb, 22 to 26. There are more. Okay. And just so that you remember, these are the ones that are being listed out in the text, but you're going to find other examples where it states a different amount, so just kind of keep that in mind. So creatine clearance is 70 to 135. Your bun is going to be 6 to 20, relatively 15. Your white blood cells should be 10 to the 5th, 10 to the power, that is. Any more than that usually indicates an infection, and that's done by clean catch method. Your sodium 135 to 145, potassium 3.5 to 5, calcium is 8.6 to 10.2. Your potassium is 2.4 to 4.4, and your bicarb is 22 to 26. And remember that those electrolytes that I just told you about, those electrolytes are coming from serum values. Serum values, that means blood, okay? So that's not what's in your urine, that's what's in your blood. Okay. So let's go on and look at some of our other diagnostic areas. So the way that I have it split up is kind of like this. And this is all radiology in some form or fashion. Alright, so we have our KUB, which are kidneys, ureter, and bladder. Of course, if you find yourself with another one, maybe you'll have kidneys, urethra, bladder. But either way, this is kidneys, ureter, and bladder. And this is done by X-ray. Right? And so we're X-raying to see what's going on as far as those systems go. The other one we're going to focus on is your intravenous pyelogram. Okay, that's a lot. IVP. Intravenous pyelogram. Alright, what does that mean? Basically, it's an IV contrast, and again, anything where it says contrast means iodine. Means iodine, and when we're going to use anything, we need to check for contrast. We need to check for iodine sensitivity, and it's also noted that we need to be checking for pregnancy. Alright, so IV contrast. It's important, of course, to check for, my goodness, iodine, check for sensitivity, check for pregnancy, and make sure you flush if at all possible after procedure. Okay. Also, you have emptying the colon, and that pops up a lot as far as these go. So empty colon and iodine sensitivity are going to be probably your prime answers here. Tell the patient that they might experience warm, flushing, or salty taste in their mouth. Alright, salty taste in their mouth. This is very similar to your retrograde pyelogram. And the only difference here is that if you're not able to identify something in your IVP, you might use this to dig a little bit deeper and go through and see the kidney at a different angle. So you have your IVP and your retrograde pyelogram. And those two are very similar, and the prep here is similar to the prep here. So that shouldn't be an issue. Alright, your renal, I'm going to put this one out too. Your renal arteriogram or angiogram. Renal, and I'm going to write it this way because it makes more sense to me. Arteriogram, alright, or aka angiogram. Alright, so renal angiogram. Basically that means we're going up through an artery in the leg, and we're going to get all the way up to by where the kidneys are, because if you remember, you have an aorta coming straight down off of that. And we're going to put in contrast there. And again, contrast means iodine sensitivity, flushing. You might need to use colon pressure as well. What else? Oh, colon prep. Blood flow. Alright, so of course, if you're going to, basically they're shoving a needle up your artery in your leg up to your kidney. So you're going to need to make sure that you apply pressure, and then you're going to need to make sure that nothing clots after the fact. Okay, so what we're checking for when somebody has gone through the artery is, 1, make sure it stops bleeding. 2, make sure blood returns to your lower extremities. That's i.e. get a pulse every 30 to 60 minutes. Blue cyanosis, capillary refill, those are all going to be important to make sure that the blood flow is working the way it should. Alright, so you have your renal arterial angiogram or angiogram. That's going to go through your leg. You have your IVP, your intravenous pyelogram, which is using contrast. Make sure you empty the colon and flushing that iodine out afterwards. And again, very similar to retrograde pyelogram, other than this one gives you a little bit better view. You can see that. Now, here's the other thing. As far as the rest of them go, they're pretty much all contrasts. They're all going to be contrasted in different ways. So when you hear one of these things, you might hear a cystograph, a urethriograph, a voidograph, or a loopograph. When you hear any of these, alright, just put the words together. Alright, cyst right here means bladder. Obviously, you know this means urethra. And this is voiding bladder. Alright, so voiding bladder, that's before and after you void. All of these are using contrast, and they're using contrast to examine different areas and their functions. That's all they're doing. When they use contrast, they're able to figure out size, location. They might be able to identify cysts. The other thing with this arterial, because we're in a vascular structure at that point, we're able to figure out the difference between cysts, which don't need as much blood flow, and cancer. So that's really beneficial too. But all of these are all contrast. They're all iodine. They're all make sure that they're not iodine sensitive. Make sure they're not pregnant. Flush if you can. And most of them are going to be some type of colon prep, minus a couple of the more non-invasive ones we'll talk about right now. But it's kind of all similar. So those are the main ones right there. You've got CT. If you're going to use a CT scan, you need to make sure that, and it's just like a super powered ultrasound. One, if you have somebody that does not like tight spaces, you might need to use some type of sedative or anesthesia, depending. So you have a CT scan, you have an MRI scan. That means magnets are going to go around you. If you don't realize, pacemakers work on magnets. So if you put somebody with a pacemaker in the MRI, there's a good chance that the pacemaker is going to malfunction, not work, ///. They react to magnets. So when you need to reset a pacemaker, you put a magnet right over it, right over where the pacemaker would be. So that's obviously not good. So watch for that. CT scans make sure not pregnant. Okay. The other ones that we have are endoscope, endoscopy, or cyst. Alright, basically, scope mean light. Alright, so I'm going to stick a light down you. What do you think are going to be some of the complications? Well, one, I might puncture something. Puncture, yes. Alright, infection. If I stick some foreign object into your body with a light on it, I run these two big risks. So what are we checking for? We're going to check for bleeding. Alright, bright red blood, obviously. Alright, and infection. 72 hours later, you're going to have your systemic reactions, maybe fever, chills, increase in white blood cell count. So those are what you need to be looking for in your scopes, especially the bleeding part. Some bleeding might happen, but it shouldn't be bright red bleeding. We need to watch out for that. And of course, because this is invasive, anything where you're entering into the body like that, you're going to need to make sure you have a consent form. So if it's invasive, you have to have the consent form. Alright, that is going to finish up all of our diagnostic radiology for urinary or for renal system. The other part here is age-related changes. Basically, everything goes down except for retention. Age-related changes. Everything goes down. Down, 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 down. Alright. So our muscular system is obviously going to go down. That means we're going to have incontinence. That means we're going to have skin breakdown. That means that we might not be able to push out all the urine. This is pretty common sense. 20 to 30% in reduction of the actual size of kidneys between like 60 and 90. The GFR is going to reduce 30 to 50% GFR rate, which again, we heard 100, we heard 125. Renal blood flow. Alright, renal blood flow is going to decrease, and that is because of erythropoiesis, or basically hardening of the vascular structure, so hardening of the veins, arteries, things of that nature. Hormone changes, those are going to be all over the place. Elasticity, especially for women, because that relates back to your muscles. You're going to have prostate. Now here's your increases. You're going to have an increase in prostate size. When we have an increase in prostate size, we are going to have retention. We're going to have an increase in constipation, most likely. And when we have an increase in constipation, then we're going to have an increase in retention. Alright, and then of course, I said about 5 times just now, retention. Alright, your retention is going to go up. So, everything is down except for anything that affects retention, or urine staying in the body, or being able to avoid that dribble drabble effect, okay? And you've got to remember that, because when you look at your body, if this is your body, you might have your urinary tract right here. Well, guess what? You might have your bowels right here, and then you've got your prostate right here. So when these things are pushing on your urinary tract, guess what? It's going to stop flow. Okay? And yep, residual will increase, retention will increase, everything else is going to decrease, and that's your age-related changes. Hormones will be all over the place, so you might see a shift in electrolytes, and because you have retention and because you have a decreased GFR, if you apply that, then it makes sense that some of your electrolytes, your buns might be higher because of excretion. Your creatines might be higher because it's not being excreted properly. So some levels will be up because your GFR is not producing quite the same amount, okay? And that's going to sum up chapter 45.